What I found is that it does not matter if you're running down a football field or you're running into a fire or you're running after a suspect or you're running down the theater to engage an enemy. Your movement patterns matter. And in some situations, that's a difference between making a touchdown and not making a touchdown. When it comes to military first responders, that can be a life or death type of situation.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow. Hello, NeuFit Nation. Welcome back to the Undercurrent Podcast. My guest today is Dr. Trent Nessler, physical therapist with a background in exercise physiology, biomechanics, motor learning, and a lot of experience that we're going to dive into today. He's been treating sport and tactical athletes for over 25 years. He's the founder and owner of the Athlete Lab in Franklin, Tennessee, and we're going to talk a lot about his practice model. Leading up to that, he's also been a published researcher, internationally recognized speaker. He's been a professor teaching at Tufts University and other places. And he's also developed a couple systems and products. He's developed the ViMove AMI, Athletic Movement Index system for movement analysis that we'll talk about, and also the National ACL Play It Safe program. He's written a book called How to Build a Badass Firefighter, and he's a black belt in Brazilian Jiu-Jitsu. So this man has done it all, and we're really excited to have you on here, Trent, to share your experience and the frameworks that you're using to treat athletes and just the wonderful work you're doing. So thanks for joining us.
Yeah, well, and thank you so much for having me. I really do appreciate this.
Yes. So to help our listeners understand a little bit about who you are and where you're coming from, can you tell us a bit of your origin story and how you got started in this particular direction?
Sure.
In the physical therapy profession?
Yeah, so I've been a PT for 28 years. Originally got into PT because my father is quadriplegic. I broke his neck when I was a very young kid and got to see the impact that physical therapists had on people's lives, and knew that I wanted to be a physical therapist. Went to PT school, and I was out for about 3 years. And I was very fortunate in the setting that I was in. We worked with a lot of Major League Baseball. I think my first 2 years, I treated nothing but shoulders. And then I started seeing a lot more knees, started seeing a lot more ACLs. And it really started to drive this passion that I had for ACL rehab. And more importantly, for the listeners, this is back in like 98, 99, 2000. So still very early on in the ACL published research realm. We were just starting to hear more about biomechanics. And what I was seeing as a clinician is I was getting these kids ready, for return to play. And I would watch them walk. I would watch them run. I'm like, man, all those movement patterns that I'm seeing there, I know that's not good for them, but I wasn't effective at that time at changing it. And so I came from a strength conditioning background. I had a strong background in fitness, strong background in powerlifting. And so I really started to dive into really trying to analyze human movement better. So I went back to school, did my doctorate with a focus in biomechanics and motor learning. And as I came out, started to develop the very first versions of the Athletic Movement Index, or the AMI. Fast forward, 2017, partnered with a company called Dorsavi, which is out of Australia. And we commercially released what is called today the ViMove Plus AMI. And that system uses a wearable sensor. It captures human movement within 1 degree of a Viacom system, so lab quality data. We capture over 4,700 data points on every single movement that we do. And what it allows me to do is in 15 minutes, I capture all these different movement patterns. And what it's done is it's really taught me better, innovative ways to create what I call a movement-based approach to really improve human movement no matter what their sport is. So we've collected data now on over 490,000 athletes across 5 countries. We've collected data on special forces. We've collected data on military personnel, firefighters, police officers. But the majority of that is primarily athletes. And so the athlete lab, fast forward to the athlete lab, what I tried to do is really take everything that I was learning and integrate innovative technologies like the NeuFit, Quickboard, neurocognitive training. We combine peptides, we combine stem cells, red light therapy, cold plunge, all of that stuff to really provide a very comprehensive approach to ACL rehab, but also just sports rehab. And so here at the Athlete Lab, that's what we're trying to do. And it's been an amazing, the thing I love about my profession is I'm 28 years into this, and most people I think stop learning about 10 years in. And I have learned more in the last 2 years than I ever thought possible. And it's been an absolutely amazing journey.
I love that. The day we stop learning is the day we start dying.
Exactly. And it's interesting to me is that a lot of our profession, I think, sometimes, forgets that, and we get too narrow focused and too close-minded, I think sometimes. And it's one of the things that I love about what we're doing is looking at new ways, new things, new ways to integrate stuff into the process, and using, evidence-based, but also innovation, and innovation sometimes doesn't always have the most profound research behind it. It's innovative, right? It's new stuff coming to the market. And so how do you, based on the science of how it works, how do you integrate that into your practice to provide the client with, a better outcome?
Love that perspective. That's a really good encapsulation of the growth mindset and also of doing what's best for the patient. I think a lot of times, especially in the more traditional medical model, there's a message of, it's going to be this way, and there's nothing you can do about it, as opposed to, well, I may not know anything to do about it, but you could go see this person, or I could try this with you. There's that sort of drive to improve versus just accept the status quo. I think that's a mindset that different people have there. And I appreciate your mindset, and I can see how that has led you to create these wonderful technologies and techniques and frameworks and everything that you're doing there. So that's awesome. Beautifully said.
Well, and I tell you, it's I think we've only begun to really understand the full scope of what is possible, and I know, Garrett, you and I have I've shared some stories with you about some clients that I've had that have just had amazing stories, and it'd be different if that was just one client or 2 clients. But, and I'm trying to capture this more on video and video testimonials, because I, in 28 years, have not seen some of the most traumatic injuries that I've seen today and the outcomes that they have. I know that you got to see the video of one of my patients, special forces guy that was shot, came in, first day, caught Quintus syndrome, had paralysis in one limb. And today he's running 3 miles at an 850 clip, and it's just now over a year out from his injury. So, and that's not just one story. We're seeing those over and over and over again. And I think, we know where biologics go, we know where nutrition goes, and everybody's been in silos. But man, when you combine those things together, the outcomes are just amazing.
That's awesome. And you're on the leading edge there. So I'm excited to dive into that. I do want to pull a little bit on the thread of movement analysis. You mentioned, I might have said dorsify,
Okay.
the AMI, athletic movement index system that you've created. So you mentioned that this system that you have is within 1% of the lab standard, the Vicon.
1 degree.
Within, yes. And the whole framework here, I just want you to help people so they can sort of visualize what the system is, because initially these movement systems had markers on milestones in the body and cameras in the lab, and they've evolved to not needing as many markers or no markers, and multiple cameras to even one camera. And so where does your system, how does it actually work? And can you just help people sort of visualize?
Yeah. So, and the funny thing is I started with 2D video technology with a product called Dartfish. Progressed from that because I wasn't able to standardize it enough. I wasn't able to replicate results, both with myself as well as other users. Then I went to kind of the Connect system. Matter of fact, we got one of the first SDKs, software development kits for the Connect when it first came out. And we're working with Microsoft on programming that for basically doing what I was doing with my eyeballs. we moved from that to Dorsa V because what I found was that those systems you couldn't replicate. Inter and intra-rater reliability was low, and what I was also finding is that the error rate was really high, and so I wanted to go to something that was a little bit more accurate. And so with the Dorsa V system today, as it sits today, we have 4 sensors. They're about this big. They have inside of them an IMU that has an accelerometer, gyrometer, and magnetometer. So it detects motion, rotation, and acceleration data all at the same time, all within 1 degree of a Viacon system. So we have 4 sensors that go on the body. We have 2, one on each tibia, and then we've got 1 on lumbar spine and 1 on thoracic spine. And so from those data points, those 4 reference points, we're able to capture hip data, we're able to capture limb data, and collectively, we capture over 4,700 data points. So we place these sensors on the individual, and then they go through a series of movements. And the movements include, they do a plank, they do squats, they do a side plank right, side plank left, and then we do all single limb tests. And that's super important, especially when it comes to return to play, because one of the things that you look at is LSI, or limb symmetry index, that comparison of the right side to the left side. And so one of the things that we do is a fair amount of the test is actually single limb performance. So we do a single leg squat, we do a single leg hop, we do what is called a hop plant, which is just basically a multi-directional hop. So they jump forwards, backwards, lateral, and then medial. And then we do an ankle lunge test. So what the system does, it captures all these data points, and then it also provides us a limb symmetry index page where the specificity of it is super high because our point system is very high. And it's not just over one movement, it's over multiple movements. So it's about 6 movements that are single limb in performance. In addition to that, one of the things that we found when you look at a lot of people moving, you find that there are some flaws with what we traditionally think about, especially when it comes to LSI. So one of the things that we found when it comes to LSI is that you can have symmetrically bad movement and you're at risk. So, if you jump up in the air and your limb goes into dynamic valgus at a high rate of speed and a large magnitude, and you do that on the other side, yes, you are 100% symmetrical, but you're 100% symmetrically bad. And so one of the measures that we added to it is what we term LQI, or limb quality index. So we measure not just your symmetry between your right side and your left side, but what is the quality of the movement between your right side and your left side. And so the things that we measure include things like, we call it tibial inclination. So we're actually getting the depth of your motion. We look at dynamic valgus magnitude. So how much does your knee move into dynamic valgus? We look at dynamic valgus speed. Let me say something about speed. We were one of the first ones to actually measure dynamic valgus speed. And one of the things that became apparent very early on in the process was that we found out that, if you stand up right now and you put your knee at 20 degrees of valgus, it's not going to hurt. But if you did that at 420 degrees per second, you're going to tear something. So one of the things that we found is measuring dynamic valgus speed was super important, because if you look at force calculations, you look at torque calculations, they all have a speed component. The higher the speed, the greater the torque, the greater the force. So we measure dynamic valgus magnitude and speed. But one of the other things that we measure is pelvic motion. And I think this is one of the things, especially when it comes to ACL risk, that's been missed a lot. And I will tell you, Tim Hewitt, who is using one of our systems, big in the ACL world, he is going to has been presenting on some of the data that we've captured, but also some of the things that means. So one of the things that we look at is when you're standing on one limb, if this is your stance leg, we look to see, does your pelvis drop this way? Does your pelvis drop this way? Or does your pelvis drop and rotate? Okay. So we call those, the first one is if your pelvis drops this way, that's more of a Trendelenburg. We have a retro Trendelenburg, and we have what's called corkscrew. So those are three typically motions that we're looking for at the hip. And what we see is that actual hip or instability at the hip in single limb performance is a greater predictor of ACL risk than dynamic valgus alone. And if you think about it, it actually makes a lot of sense, because as the pelvis tips, the center of mass moves. So when you land on one limb, and if your center of mass is way over here, it can actually drive your knee into that dynamic valgus position. So the beauty of that is that, with all these movements, because I have a lot of therapists tell me that I don't need a movement assessment system to look at human movement. Well, really you do, because you can measure it, but how are you going to know if they improve from test 1 to test 2? Because there's a lot of rater bias there, right? I'm treating therapist. I want to think that my stuff is working, so I may score them a little bit better. But the sensitivity of the AMI and the fact that it's measuring dynamic valgus speed and pelvic motion are some of the key indicators for return to risk as it relates to ACL return to play.
That's fascinating. So I was going to ask what are some of the most interesting conclusions or interesting learnings from the data, and that is a fascinating one. So that certainly answered my question. So you're saying that the greatest predictor of near ACL injury is pelvic instability in single leg stance.
Yeah.
Am I getting that right?
I can't say definitively that that's the case. We just have data that indicates that may be the case.
Okay,
but
that's fair.
we know dynamic valgus is bad. We know magnitude of dynamic valgus is bad. We know that speed of dynamic valgus, we now know that the faster you move into dynamic valgus, that is bad. And we now know that the pelvic stability plays a critical role in the loading to the limb, especially in landing. Interestingly enough, so I've been training jiu-jitsu. I knew at some point I had to mention jiu-jitsu, right? Because I'm a jiu-jitsu guy. But I one of the things that it's taught me a ton, and I was telling one of my students this today, is what I have learned about biomechanics and motor learning was great what I learned in school. But what I have learned from the last 13, 14 years of training martial arts has taught me way more about biomechanics and how to manipulate biomechanics and what that manipulation does to loading of limbs. And when you think about and you look at where the center of mass, the upper body is at landing, it is going to dictate the loading pattern for the lower extremity. So to me, the more I got into martial arts, it just made sense. And I started to address it, but as the data comes out and it keeps coming out stronger and stronger, it just really drives more and more what I do clinically, because it's changed what I do clinically, and that again, going into the athlete lab, that's part of the reason I developed the athlete lab, because I wanted to have a center where I could take what I'm learning from the data and actually apply it to clients and see what does it do.
Well, it's a perfect segue into the next topic here of if you have these movement issues, these biomechanical inefficiencies or dysfunctions, and then the question becomes, how do you work on it? You don't just tell someone, hey, stabilize your pelvis when you land, right? It's a subconscious motor control pattern. So can you share with us your framework for when you find these, this pelvic instability, for example, or other findings with your movement analysis? How do you approach then the process of improving those movement patterns to reduce the risk of injury or re-injury?
Yeah. So one of the first things, so I treat a lot of ACLs. And one of the first things I think, there's a ton of research on the quad and the importance of the quad, and controlling a frontal plane motion of the knee, right? And so we know there's a lot of really good studies out there that show that even at 9 months, there can still be a quad deficit. There can still be a lot of dynamic valgus occurring at the knee. And at 2 years post-op, despite the fact that they've had PT, despite the fact that they've returned to sport, that these movement patterns can persist in single limb performance. So one of the things that it's taught me is that I need to be a lot more aggressive in the earliest phases of ACL rehab, and especially as it comes to quad recruitment. And quite honestly, that's where the NeuFit it has really been a huge value add to my practice, because I use it exclusively, and I combine it with blood flow restriction training, or BFR, in day one, day two post-op. And in understanding for listeners, I'm dealing with a very athletic population. I would say 95% of my practice is sports, so that's an unusual setting. So I can be a little bit more aggressive with people. That being said, getting that quad to fire in the initial phases of rehab is absolutely critical to control of the limb at 9 months and at 2 years. So doing that in the very earliest phases is absolutely critical to that. The other piece that it's taught me is related to the pelvis, is the importance of rotational training, number one. And number two is what I call fatigue state training. And that really, for anyone who knows the ACL Play It Safe program, that was one big lesson that I learned from the ACL Play It Safe program, was that the way the program is implemented is at the conclusion of practice. It's not done at the beginning of practice. It's done at the conclusion of practice. The thought process is that you're taking all of that fatigue that you had from practice and you're bringing that into your training session. So number one, the training session does not have to be as long, doesn't have to be as intense, because they're already tired. But more importantly is that you're training them in a fatigue state. So from a motor learning perspective, what you're doing is you're training them with proper technique. Is you're training them so that when they are fatigued, these are the movement patterns that they rely on. And so with the ACL Play It Safe program, it was designed to be done at the conclusion of practice in that fatigue state. I call it fatigue state training. And so a lot of what I do from an ACL perspective is really try to get people super duper tired, make sure that it's a very intense session. And then I work on specific control of motion, specific control of rotational motions, specific targeting of the glute medius, et cetera, to give that stabilization in that very tired state. A lot of rotational training. I do a ton of rotational training, not like a Pilaf press, but more, I do a lot of stuff, in a shout out to Kaizen Vector. I use a lot of stuff with Kaizen Vector. They've got a torso strap that I basically wrap around someone, and it gives a rotation at the shoulder. It gives a rotation at the hip, all while standing on one limb. So again, part of what I do is I put people in that really tired, that fatigue state, and then put them through this rotational types of training where they have to stabilize their body in that tired state and control the entire limb in a single limb performance.
So that vector strap that you mentioned, is that the one that it sort of wraps around your body, almost like a toga or something like that, sort of wraps around, and you rotate, and then and it resists you in rotation, right?
Yes.
Okay.
Yes, and you can load those. It comes with a tube, and the tube will have anywhere from 35 pounds of pull to 110 pounds of pull. So you've got a pretty significant rotational stress to you. And again, for me, resistance training or targeted resistance training is all about directional pull. So I have it pulling kind of at a lower diagonal pull. So it's really pulling your shoulder. It's really pulling your hip. And you will feel it. And if anybody's interested, they can go on my YouTube channel. I've got tons of videos on there with the Kaizen Vector showing that. But it's really the ability to resist those rotational stresses in that tired state that I find makes the biggest changes in movement as the athlete progresses back to sport.
And you are qualified to say that because you are actually testing objectively their movement and seeing whether the data is changing or not, or whether movement is objectively improving or not.
Yeah, in our return to sport testing is pretty intensive. It is comprehensive. I would say it's comprehensive and intensive because we do an AMI test that includes all the movements that I just told you, in addition to a 30-yard ACL decel test. So we capture movement data during a max acceleration and deceleration. So we capture that. We also do
what data do you capture? What data do you?
So it's we capture ground reaction force. We capture absolute LSI. So how much variance there is between your right side and your left side. We also capture what is called IPA, initial peak acceleration. So how you're controlling your limb coming into the ground.
And are you able to do that with the Dorsa V, the 4 sensors we talked about? So this is not force plates. This is with what you already described.
This is what I've already described.
Oh, cool. Awesome.
So we do that piece, and then we do a neurocognitive test. So we use the quick board for that. So we do a neurocognitive test, and then we follow that up actually with a force plate test. The force plates that I use are strength by numbers, and I've got a whole sequence. So they have a squat, they have a squat pause, they have a squat jump, and then a single leg hop. And again, what I do is I look at both your symmetry during the squatting motion, but also what we call reaction force. I don't know why I'm getting fireworks there, but the other thing that we get is your reaction force. So what I see is that one of the things that we measure with the AMI is called lateral shift. So if I put a plumb line right down the center of you and I have you do a squat, your hips should remain relatively equal distance from that plumb line during your squat. Now, it's very normal based on our data that you shift back and forth within about 8 degrees. So it's normal to kind of have a little bit of a shift back and forth within 8 degrees. Now, if that shift is off to one side only, that's not normal. And if it's bigger than 8 degrees, that's also not normal based on our normative data. So one of the things that we started to notice very quickly was a lot of athletes, especially ACL athletes, is that they shift their weight over to their non-operative side. We call that a lateral shift. Now, one of the things that we've seen is that there's also a correlation of that lateral shift to kinesiophobia. So athletes who present with a lot of kinesiophobia, they'll tend to have a greater lateral shift. So one of the things I wanted to be able to do was to be able to measure the force variance between the right side and the left side if they have a lateral shift. And so what we found with the force plates is, now that I put the force plates into the equation, is that we can correct a lateral shift. But then when the athlete goes to generate their force, so the reaction force, so they squat down, and as they're pushing up, they'll still tend to load more to their non-operative side. So from a force production standpoint, I want to correct that. But again, that's where the objective data really comes into play, because it allows me to capture all of that information and make a much more informed decision. And two, it allows me to see, am I truly making a change in your data based off of the clinical interventions that I'm doing? It's not a guessing game anymore. It's data.
I love that. I love that approach. We've done a couple episodes recently with people who are doing electrodiagnostics with EMG and nerve conduction velocity testing. And it's awesome to have both subjectively, someone will say, hey, I have more sensation and I can feel the ground better and I feel like my balance is better. And then to also see an increase in EMG amplitude in the tibial nerve or sural nerve of their lower leg, that shows us that there's real changes happening there in the underlying physiology and even anatomy. I mean,
right,
tissue
for sure.
there. So I love that. And You mentioned it in passing, the Play It Safe program. I just want to go back and hear a little more about that for our listeners who may not be as familiar with that. So you talked about program being done after practice in a fatigued state. So is this a program that is shared with coaches at a club level? It's not necessarily physical therapy specific, right? It's more preventative, and it's
Yeah.
done at the more of the coach or trainer level.
Yeah. So I should make everyone aware that is a program that is owned by Select Medical. At that time, I worked for Select Medical when we brought this to the market, and it is still available. I actually have a copy of it on my YouTube channel, and how that came about was is some original research that I was doing with ASMI in Birmingham, American Sports Medicine Institute. So I spent a number of years in Birmingham with Champion Sports Medicine. And one of the projects that we did is very early phases of the AMIs. We were doing movement assessments on athletes and then trying to find a program that we could do that would make some changes to the assessment that we were performing. And so that's really where the ACL the ACL Play It Safe program came about. And it was 7 very simple movements based off of what we were capturing from a data perspective. And, when you see it, it's not really rocket science. It's just, it's a combination of the movements that we actually assess with athletes. But the difference is that we do it when they're tired. Because one of the things I found very early on was we were doing a research study, and we were assessing a bunch of Division I soccer players, female soccer players. And I went through almost the whole team, and the last 2 players to come in were like the stud players. They were supposed to be the very best players on the entire team. So they came in, and I did assessments on them, and they looked horrible. They looked worse than anybody else. And I was like, holy cow, like these are your best players, and they move like horribly. Like, what in the world is going on? So I actually talked to the coach about it, and he's like, well, yeah, it makes sense because I just put him through a fatigue protocol. He's like, we were out on the field, and what I know is that what I want to see is what a player plays like when they're really, really tired, because I know they're going to move differently. I know they're not going to be as explosive. I know they're not going to be as reactive, et cetera. So here's a Division I coach who's figured it out and had implemented a fatigue protocol into his assessment of players to really see where they're at. And so I was like, holy cow, if that works for that, what would it look like if we actually did a fatigue protocol? So I started to really dive into the fatigue research and fatigue protocols. And I came across one, it was first published in the Journal of Athletic Training in 2012. Forgive me because I don't remember the authors. But it was called the FAST-FP. It's a Functional Agility Short-Term Fatigue Protocol. And what I found is with my really high-level players, Division I soccer players, mixed martial arts, et cetera, is that sometimes you evaluate these athletes from a movement perspective, and you don't see a whole lot of deviation. Well, this is also a high-level athlete. So what we would do then is we would combine the FAST-FP before we did the movement assessment and immediately follow that with the movement assessment. And we saw drastically different movement patterns. So I'm like, well, that makes sense. So now what that tells me is that I need to train them so that they move better when they're actually tired like that. And that's really where the first version of the ACL Play It Safe program came about. But it also addressed a major problem with the implementation of injury prevention programs into sports. Number one is you don't call it an injury prevention program, you call it a performance enhancement program, because not only does it improve biomechanics to reduce risk, but it also improves biomechanics to improve athletic performance. So I found that coaches were much more receptive to that term, performance enhancement, than they were injury prevention. Second thing is the length of the program. A lot of those programs would take 30 minutes. And the coach is like, hey, I don't have that much time to spend on an injury prevention program. So what we ended up doing is by taking that fatigue into the program, now the program takes 10 to 15 minutes versus 30 minutes. So 10 to 15 minutes is very doable. Matter of fact, if you look at the research, there's papers published out there that show once you go up to 15 minutes, the compliance of the program starts dropping off. For every minute over that, it starts to drop off because it's too much time. So it helped me address two major things. Number one is the fatigue that I was seeing when they were tired. So I could actually work on those movement patterns in that tired state. And then secondly, is it helped me address the time issue that coaches were struggling with. So I know that was a very long-winded answer to your question.
That's great. I'm learning a lot here, so I imagine those listening are as well. Can you share examples? You mentioned there's 7 movements done in a fatigue state. Can you share examples of what some of the movements look like?
Plank, side stepping with a TheraBand, single leg squat. I mean, it's not the cool thing is it wasn't. What I found is that some of the programs that are out there try to get too complex and start putting in these different movements and things like that. I'm like, you know what? What's the best way to improve performance on a single leg squat? Number one movement for prediction of ACL risk is a single leg squat. Reference on that is Timothy Hewitt. Okay, so Tim Hewitt says the number one movement to address or to assess risk is a single leg squat. And I'm like, well, how do you improve a single leg squat? Maybe you do a single leg squat. Sounds good. So the other thing that we know that adds into that, we know that if you have core weakness, there's several studies out there that show that DeBlazier is one of them. American Journal of Sports Medicine 2018. Basically, it showed that poor performance on a plank and side plank, you're 3 times more likely to suffer an ACL injury. So again, what am I going to do? Okay, so the research shows me that you got to improve your performance on a plank and a side plank. What should I do? Well, let's do some planks and side planks. So it's as complex or as easy as it sounds. It really is easy. So we're doing a single leg squat, we're doing a single leg hop, we're doing planks, side planks, glute medius work, etc. So again, it's not super hard. It's all done as a superset, and then you run through it again. And I use a concept that I was teaching at that time about repetitions to substitution, is that you simply do repetitions to substitution. So everybody's neurological system is different. Everybody's going to fatigue a little bit differently. And so if you cannot perform the exercises without substitution, that's where you stop. Some days that may be 3 rounds. Some days it may be 2. Maybe you had a very hot practice and you're completely exhausted. Maybe you can only go 1 round, and that's okay because you're still training those movement patterns in that very fatigued state. The thing is about fatigue state training is you do not want to train bad movement patterns because those will be the patterns that you resort to when you are tired. So it's super important to make sure that especially when you're doing fatigue state training, is that the technique is correct. And if you can't do it correctly, nix the exercise.
Thank you so much for listening to the Undercurrent Podcast. If you're interested in learning more about how NeuFit and the NEUBIE can impact your life, please visit our website at www.neu.fit. That's neu.fit. So you can learn more about how it might integrate into your professional practice, how you can use it as a patient, and you can also connect with our team there. Yes, the SAID principle, specific adaptation to imposed demand. We are always getting better at exactly what we're doing. So if we're moving badly, we're getting better at that.
Exactly.
That's really great. I love hearing your perspective on that and some of the history here. And there's a lot of really good information here. So I also I would like to hear some, because I mentioned in the intro that your book is called How to Build a Badass Firefighter, and I know from our prior conversations that you've done movement analysis on, evaluated, and worked with multiple thousands of firefighters and also other tactical athletes and martial artists. So can you talk to us a little bit about your work in that population and what you found that's interesting? I mean, we have some very interesting findings around ACL injuries in youth, high school, college athletes, of course, here. What are some analogous findings and learnings from your experience working with this other population?
Yeah, when I first started going down this road, I was recruited to work with a company that solely worked with first responders. And initially, it was a question around, hey, I really like the work you're doing in sports with the movement assessment and things like that. Do you think that this applies to the first responder? Does this apply to military personnel? So I started to do a little bit deeper dive into military data, because military's got a lot of really good data out there. In the police and fire industry, there's not as much good published information on movement related to injury risk. However, the military's got a fair amount. And so what I found is that one of the number one injuries in the military is patellofemoral issues, especially with military training. And so when you look at the research related to patellofemoral issues, especially with military training, it goes back to the same things that we see with dynamic valgus. And so, what I found is that it does not matter if you're running down a football field, or you're running into a fire, or you're running after a suspect, or you're running down the theater to engage an enemy, is that your movement patterns matter. It doesn't matter in some situations. That's a difference between making a touchdown and not making a touchdown. When it comes to military first responders, that can be a life or death type of situation. And so what we found is that these same movement patterns have a huge impact on first responders. And so probably one of our largest groups that we did work with was Memphis Fire here in Tennessee. So they've got about 3,000 firefighters, and we do an assessment on an annual basis where we would basically process about 120 firefighters per day doing movement assessments on them. What we would do is we would then push that data over to an app that we had created that would auto assign each firefighter a workout that they would do based off of their individual data. And then we could track their workouts. We could progress their workouts. They could have interactions with our team to check their technique, or if they've got an issue that's popping up, things like that. And what we found over that span of 1 year is that we saved the department over $1.2 million. And that was not just from injuries, because when a firefighter is injured and they're off the job, they're not going to send the fire truck with just two guys. They're going to replace that person. And there is a huge overtime cost to replacing somebody when they're down. And so when you look at the full scope of an injury, when it relates to first responders, especially first responders, there is a downstream effect of that. And that includes the overtime cost. But there's also a negative effect to that too, because there's the downstream effect of you've just worked a 24-hour shift. You had 12 calls on your 24-hour shift. You've gotten probably about 2 hours of sleep, and you're getting ready to go home, and you get a phone call that you got to go cover another 24-hour shift where you're going to get another 2 hours of sleep. So now you've had 4 hours of sleep over a 2-day period. And so the psychological impact that has to the first responder is huge. So when you think about the impact of injuries in that population, you're thinking not just about the individual themselves, but also the cost for the overtime and the mental cost that it has for those who have to cover those shifts, because it is devastating. What we found as part of the reason I wrote the book about how to build a badass firefighter is how movement applies to the first responder. So in the book, what I do is we talk about injury rates in firefighters. We talk about some of the common movements that you see, what those movements can cause, joint by joint, going from the foot and the ankle all the way up to the low back. And then we go through, how do you assess that? And then based off that information, how do you train it? And then how do you message that both to the first responder, but also to administration. And, that was probably some of the most rewarding work. That led further to then starting to do that same thing with military personnel. And, we did some testing on some special forces folks. And the cool thing is that even at that level, at the highest level of military operations, is that you see the same movement patterns. And then when you explain to them what you're seeing and the impact that can have throughout the entire kinetic chain, they're like, oh, that's why I have SI joint issues, or, oh, that's why my knee hurts, or, oh, that's why I keep getting shin splints, because of what it helps you do is identify along the kinetic chain where the weaknesses are in the links in the chain. And it helps you create a much more targeted program to address those links in that chain.
That's awesome. And I think one big point that you mentioned there is that human movement is human movement, whether you're a high school soccer player or a first responder or a special operations soldier. you're a human first, and the same biomechanical principles apply, and the same frameworks there. So that was.
So let me share a story with you.
Yeah.
It's a little unusual. So I was working with this gentleman who was a special operations guy, and we were working a lot on stability and single limb stability and whatnot. And he was telling me about an operation that he was on, and he's like, I was kneeled down and I was kind of in a funky position, and I had my dot on somebody's forehead. And he's like, I was thinking to myself how stable I was at that point. So the difference between running and life, like it was just, I couldn't believe that he was in that situation. And what he was thinking about is how stable he was in that particular position. But it makes a big difference.
Yeah. I'm sure the gun he had is going to have some pretty forceful kickback there too. So you need to be stable. Yeah. I would like to come back to your clinic now. So back to the athlete lab in Franklin, Tennessee, and talk about, I know you're actually in the clinic now and have a room full of athletes recovering from their own ACL injuries and reconstruction surgeries. And you and I have talked separately about your protocol. Of course, you've already mentioned using the NEUBIE, mentioned at least in passing BFR. I can't remember if we were recording yet or not when you talked about the BFR course that you actually teach, but can you talk about the framework that you have? Because I love it. It's very holistic when you're working with athletes as they recover from their ACL injury and surgery. It's a very holistic framework. You're looking not just at biomechanics, which of course we've talked about for the first 45 minutes or so here, also looking at other things that affect the healing process, like biochemistry and nutrition and things like that too. So can you just give us a sense of what your overall framework and techniques or treatment protocols look like?
Sure, absolutely. Number one, I am very blessed to be where I'm at. I've got a cash-based business. I don't take any insurance, and I feel very blessed that about 95% of my, I'd say at least 95% of my practice is sports. Majority of my practice, probably 80%, are fighters. I would say another 10% of that, special operations guys, retired Green Berets, retired Navy SEALs, all who are still training at a high level. And the beauty of what we do is anytime somebody comes in, first of all, I show them around the clinic because our clinic is a little unusual. We have a cold plunge tank. It sits at 39 degrees. It does circulate. We have a hydrotherapy bed that we use. We have Normatec compression systems that we use. We have a red light therapy bed that we use. Actually, we combine that with the NeuFit in the vagal nerve response and vagal nerve reset, where we combine that with red light therapy. I also talk to my clients about, it's not your traditional PT. We are going to address your range of motion. We're going to address your strength, neurocognitive, all of those pieces, but we're also going to address your chemistry. and what's happening on you on the inside. So we're going to do things like BFR, which improves your growth hormone release, your IGF-1. But in order to do that, you have to have the chemistry available to do that. So that means that we're going to address your nutrition. So I actually give clients nutritional recommendations, things like collagen peptides, creatine monohydrate, protein intake, things like that. We also use some biologics. We do work with a stem cell company to provide stem cells to those who need it. And we do a lot with peptides. Peptides, in my opinion, are the future of what we should be looking at as far as a rehab perspective. And so we are, I would say, probably on the forefront of how we integrate peptides into our post-op surgical cases. And I'll tell you, again, in 28 years, and you and I shared before the start of this, I have seen some very dramatic cases that I've not seen in my career in my lifetime that have had results like nothing I've ever seen before. And that includes, for anybody that wants to see this, you can go on my Instagram. I've posted these videos on there. One is a total knee dislocation. One of my fighters had an opponent do what's called a jump guard technique, landed on his thigh, took his knee to about 120 degrees of extension. So he tore his ACL, PCL, LCL, MCL, and ruptured his hamstring. Fortunately, he didn't have any neurological or vascular compromise. But here he is. He's 1 year out. I just posted some pictures of him the other day. He's back to grappling. He's back to training. I've had one of my special forces guys that was shot, who suffered a cauda-equina syndrome. We did peptides on him. We did stem cells on him. He is just about 1 year out from his gunshot wound. And he's running 3 miles in an 850 clip. These are cases that I just never knew what was possible. I tell my tagline for my clinic is helping athletes make the impossible possible. Because what I find is that when you combine all of these innovations, red light therapy, class 4 laser, we have shockwave, and you combine the biologics, your stem cells and your peptides, and you combine the nutrition piece of it, and you combine that together with what we do traditionally as physical therapists, the outcomes are absolutely astounding. And I am, again, I'm trying to record this more and more, just because I think it's telling an amazing story. But what I'll say is that the first thing that it comes with is instilling hope in people. Caleb, who you've met, and I can say his name because he was on Marcus Luttrell's podcast. If you don't know, Marcus Luttrell is a lone survivor from the movie Lone Survivor. He was the lone survivor. Caleb was on there. He's going on Sean Ryan. He's going to be sharing his story on Sean Ryan podcast. And Caleb, his very first day in the clinic, he had been robbed of all of his hope from the medical system. He ended up here by chance because another special forces guy on his team, one of his teammates, I had treated as well. So he came in, totally deflated, totally, loss of hope, and simply providing him some level of hope and understanding, like, we can work with this. And what he has been able to accomplish goes beyond me. It's not me as a clinician. It really is instilling that hope and allowing him to serve his warrior mindset, to drive. I tell people all the time, I'm going to kick your butt, and I'm going to kick your butt hard. But you got to have the mindset that's going to allow me to do that, to take you where you don't think you can go and see what's possible.
I love that. I love that. And that is something that we share in our ethos here in the way that we approach rehabilitation. I think a lot of what people do in rehabilitation is going through the motions. It's not stimulating enough to make a difference. And that's why techniques like the NeuFit method and using BFR and, what you're talking about here and training in a fatigue state, we're actually stimulating, challenging the body enough so that it actually has a reason to respond.
Yeah, absolutely.
That's one of the big keys there. We have covered a lot of ground. As we wind down here, Trent, we've talked about biomechanics and movement analysis and some methods of treatment and some of your business model there at the Athlete Lab. Is there any more that you wish to share, or that you feel like we need to fill out any details or add in another piece into the mix?
No, the biggest thing I would say is that, especially for maybe that clinician who's 5, 10, 15 years out, is, you know what, it's just begun. There is so much more to learn. And I think as long as you keep your eyes open and have that eagerness to learn, we as a profession, I believe we are on the cusp of some amazing stuff. With the integration of these different things like red light therapy, class 4 laser, peptides, all of that, I think that we have only just begun to see what is actually possible. And I think that's going to do nothing but get better and better over the next 10 years. And it excites me for my profession, for those who are willing to move and move forward versus being stuck in what we used to do back in 1998 when I graduated.
It is. It's a very, very exciting time. And for people who are inspired by this conversation here and want to learn more about you, I know we've mentioned your Athlete Lab business name. You mentioned your Instagram. Can you tell everyone your handle and the best websites and where to find you?
Yeah, it's BJJPT_ACL_guy. That's my Instagram handle. You can find me also. My clinic is theathletelab, all one word, .org. And that'll take you to my website. And, I encourage you, go on there and hear a couple of our stories. We've got some pretty amazing people sharing some pretty amazing stories. And then, obviously I'm on LinkedIn as well as Trent Nessler. So love to connect. I'm very responsive. So if you have questions, happy to. I do teach BFR certification course, an AMI certification course, treating the combat athlete course. And an ACL course, obviously. So if you're ever interested in those are available too.
Awesome. You have found a way to make the most of your time. That's for sure. I have a lot of respect for you and everything that you're doing. And as we do wrap it up here, last question, Trent, if you could shout one message from a rooftop for everyone to hear, or put one message on a billboard for everyone to see, what would that message be?
There is a little bit of a story behind it, and that is my father broke his neck in 1979, became a quadriplegic overnight. And when I got out of PT school, I was seeing him do things that he shouldn't be able to do. And we got him up and walking again after 25 years in a wheelchair. From a wheelchair, that guy built the largest construction business in Arizona. And today it's one of the largest in the US from a wheelchair. And what my father taught me is that you are not limited by barriers. You're not limited by challenges. You're limited by yourself. And, if you don't like your situation, change it. And you will never fully feel what you can accomplish if you don't try to accomplish. And you don't fear failure, because you will fail. And that's how we learn. But the true success comes when you pick yourself up and you do it over and over and over again. That's one thing that jiu-jitsu has taught me. I've been beaten up for 14 years, and at some point I'm going to get better.
That's right. That's fabulous message and fabulous conversation overall. So thank you very much, Trent, not only for coming on the show and sharing your experience and perspective. Thank you also for the incredible work that you're doing to advance the physical therapy profession and to teach others and really pay it forward. So I appreciate you very much. It's been an honor getting to work with you in the past couple of years. And thanks again for coming on the show.
Thank you, Garrett, very much for having me.
And thank you for tuning into this episode of the Undercurrent Podcast. We'll see you on the next one.